Welcome. So I'm going to use this short lecture to describe a recent study, Physiotherapists' recommendations for examination and treatment of rotator cuff related shoulder pain. And I want to do this because I think it will be useful revision for students preparing for exams, but also a helpful point of reflection for many clinicians. Just to acknowledge, this is the full reference for the paper and also with full acknowledgement to my co-authors. So the background to this is that when you think about common shoulder pain presentations, there's a wide range of diagnostic or descriptive terms used to explain many of the common clinical presentations that we see in musculoskeletal practice. There's a wide range of diagnostic tests. I'm thinking about the plethora of special orthopedic tests, symptom modification tests, etc., and also a wide range of imaging that patients with these common pain presentations might be exposed to. So as well as this diagnostic variability, there's also a range of different treatment options that might be available, including exercise, manual therapy, within the domain of physiotherapy, also steroid injections and surgery. But based on recent randomized controlled trials and systematic reviews, where clinical intervention is required, remember, just because someone has a pain problem doesn't mean they need clinical intervention, but where it is indicated, exercise is recommended by most as the first-line intervention of choice. And that's largely justified not because it's superior to other treatment modalities, but tends to offer comparable outcomes, but at a lower cost and with fewer risks than, for example, surgical management. I think that's an important point to remember. That's our current state of understanding. But when you think about exercise for common problems, there's little research evidence to inform what constitutes an effective exercise program. So I'm thinking about the type of exercise, the dose of the exercise, the sets, the repetition, how long that should be performed for. Now, I've undertaken with other colleagues a previous systematic review, and the best really we could get from the evidence at the time is that for rotator cuff related problems, some level of resistance to the exercise seems to matter, although again that optimal level is unclear. Higher repetitions, higher sets seem to confer superior outcomes, so this recommendation was based upon studies that compared 2 sets, for example, to 3 sets of exercise per week, and the more patients did, the better they seemed to do, but the upper limit of how many is still unclear. Also, how often people should do that exercise. And what is apparent, though, is that most exercise programs should demonstrate clinically significant benefit by 12 weeks. If they're not showing benefit by that time, then the chance of success is significantly diminished. But the important message here is that people do need time, and they should expect that time is required to affect good clinical outcomes. So essentially, we've got some guidance, but there are still a significant number of unknowns. And it's important that we understand more about this because it might mean that across the country, across the world, we're experiencing suboptimal levels of exercise prescription, which might lead to patients not getting as good outcomes as they could with exercise-based approaches, meaning that they move on to more costly, invasive, and risky interventions, such as steroid injections and surgery, which are currently of questionable benefit. And I think this is a valid concern when you look across surveys of current practice, and exercise prescription is variable across the physiotherapy profession. So in that context, I guess a context of uncertainty really, with so many unknowns, the aim of the study that I'm about to describe was to enable a shared understanding of rotator cuff related problems, a common shoulder pain presentation amongst experts. I'm very aware that many people, many individuals have strong opinions, but those strong opinions differ across individuals. So we don't have a strong community message to deliver. So the aim of this study was to try and reduce those mixed messages, inform physiotherapy practice, and by that I mean use the findings more as a point of reflection than definitive or gold standard guidance. So almost could we develop something here that would enable people to reflect on their own practice, think, well, this is what I do, what do other people do, and what are the reasons for that? And potentially the outcome of such consensus procedures that I'm about to describe provide a useful basis on which future research can be developed. So very briefly, the methods, it was a consensus group approach with 9 expert physiotherapists with a recognised interest in shoulder pain. They were invited to take part. As a lead author, I developed a list of common questions that we might want to address in a consensus approach such as this. And these questions were largely based upon the consensus methods undertaken by others. So the list was generated, circulated around the group, feedback was requested, and then that refined list of questions was then used for the subsequent consensus process. So the questions that we agreed on were then recirculated to the group of experts, and there was a request for them essentially to answer those questions. The process that was then a summary of those questions before asking the group to validate that summary. And then as a group, we met and we discussed the comments in response to the questions, and the group were asked to vote on whether they agreed that was an important factor in this clinical condition or not. And where a majority of the group agreed it was an important factor, that was carried forward into the summary and the output from the paper. But it was agreed quite early on that, this might make some smile, that although a comment carried through to the narrative summary was reflective of the majority of the group, it did not necessarily reflect the view of all those individuals at that time. And really, this is the only way that you can make such consensus methods work. So this was the first question that was posed to the expert group. What key information is required from the history to raise the index of suspicion of this classification or diagnosis over other shoulder pain presentations? So we're thinking about loosely rotator cuff related problems. And the majority opinion from the group is that for them to raise the index of suspicion of this subgroup of shoulder pain, pain should be broadly of the deltoid and upper arm, rather than below the elbow, for example, or specific points around the shoulder or around the neck. If there's complaint of subluxation or dislocation as the primary problem, then the index of suspicion of a rotator cuff related problem would be reduced. And so clearly then you'd be thinking about issues of instability. This type of shoulder pain is typically activity related, so activity can make it better or worse, but typically it's worse when people are reaching overhead, behind their back, with minimal pain at rest, except when they're lying on the affected shoulder. And pain in the neck, reproduction of shoulder pain and movement of the neck, and distal neurovascular symptoms would reduce the index of suspicion of this being a rotator cuff related problem. So you've got some suggestions around the history from the expert group there. Did the group consider that age, gender, occupation were relevant factors within diagnostic reasoning? Well, the majority opinion was that changes in occupation or participation demands, rather than occupation alone, were relevant in raising the index of suspicion. So not so much the job, but it's changes in that job or changes in the things that they did. But in terms of age and gender, a majority opinion couldn't be reached. Then, what key information is required from the physical examination to confirm this classification or diagnosis? So the majority opinion of the group is that there should be no significant loss of passive range of motion in any direction, particularly lateral rotation. So I guess what the group were looking for there is to exclude the diagnosis of frozen shoulder, for example. Familiar pain should be reproduced with loading or resisted testing, and for these rotator cuff related problems, that's typically abduction and lateral rotation, although not exclusively. Movement of the neck should not produce or abolish the shoulder pain, but of course should be examined. And if you find that by moving the neck, examining the neck, that changes the shoulder pain presentation, then that would change your focus, potentially, from the shoulder to the neck. And the expert group would not expect to see any neurological signs in this subgroup of shoulder pain. So what is the role of imaging in confirming this classification or diagnosis? I mean, this is an important question for the group to consider, given the rise in prevalence of imaging across professional groups. But the majority opinion from the group was that imaging is useful to rule out red flag pathology if the index of suspicion is raised during the history and physical examination. So it's only when the index of suspicion is raised. So for example, if you're thinking, are we dealing with a tumour here, someone who's unwell, has a fever, or has suffered significant trauma, which might implicate fracture, or if you're suspecting dislocation. But aside from that, in the absence of stiffness and with a consistent history, as described previously, imaging would not be indicated initially, according to the expert group. And the justification for this was partly because of the poor correlation between pain and structural pathology, the rotator cuff tear being a good example, where there are a number of people that we see in the community with asymptomatic cuff tears that have been picked up on scans. Importantly, from a physiotherapist perspective as well, the imaging findings in this context would not influence the non-surgical management options. So whether you have a rotator cuff tear, for example, wouldn't necessarily change your approach to improving capacity, capability, addressing the pain that patient complains of, at least from a physiotherapy perspective. And one of the concerns from the group was that scan findings, if used too early and not communicated well, might be a barrier to patient engagement. So, for example, if they have an understanding of a structural pathology, such as a bone spur or a rotator cuff tear, the patient might legitimately ask, well, how can physiotherapy address that bone spur or that rotator cuff tear? And of course it can't, but that might not matter. But if the patient has that understanding early, that could be a barrier to engagement with physiotherapy and exercise programs, for example. But the group felt that there may be a role for imaging if patients don't follow the expected trajectory of improvement. So essentially, it's the response to treatment rather than necessarily requiring imaging as a first line thing. Now, many of you will be aware that when we talk about the rotator cuff, there's a whole range of descriptive terms that people use, so, such as previously subacromial impingement syndrome, rotator cuff tendinopathy, tendinitis, tendinosis. So the question was, what is your preferred terminology? And the majority opinion of the group that the preference was for the terminology to be rotator cuff related shoulder pain, or more simply, a weak and painful shoulder. The recommendation from the group was that we should now avoid using the term impingement with these patients because of a lack of validity of that description, and potentially because of the negative effects it can have on the patient, their understanding and then engagement with treatment. But it was clear from the group that discourse is still needed regarding the most useful terms. Even though we're recommending a rotator cuff related shoulder pain or a weak and painful shoulder, they're still imperfect descriptors and the conversation needs to continue. So in summary to the expert group, what is rotator cuff syndrome? So here we're using rotator cuff syndrome because these were the questions posed before the group agreed on rotator cuff related shoulder pain. So the majority opinion was that rotator cuff related shoulder pain can be described as symptoms of pain and signs of weakness related to the rotator cuff when loaded, and movement-related shoulder pain without significant stiffness. So that's how they're conceptualizing rotator cuff-related shoulder pain. And the next question, and this can be quite challenging actually, how do you explain rotator cuff syndrome or rotator cuff-related shoulder pain to your patients? And the majority opinion was that this is an issue with the muscles and tendons of the shoulder. They're lacking strength, capacity, tolerance, and fitness. So that's why they complain when you lift or move your arm. So that's the agreed description that the expert group would use. What are the preferred treatment methods? Well, the majority opinion, perhaps unsurprisingly, from a group of expert physiotherapists, and this is a point for you to reflect on, one of the limitations of this study, but the majority opinion of the expert physiotherapists were that the preferred methods of treatment were loading through exercise, And this should include both progressions and regressions, so enabling the patient to increase their exercise, but also take a step back when necessary. And that exercise should be prescribed within an acceptable symptom response, but a response that is acceptable to that individual patient, not a group response, not a response that's acceptable to that clinician, an acceptable symptom response to that individual patient. So for some, that will be no pain. For some, it will be higher levels of pain. The group recommended progressive loading of the upper limb, but also incorporating the kinetic chain, which would include a graded exposure to painful movements or activity. The group felt there might be a role for cognitive behavioural principles if there's evidence of avoidance behaviour, so progressively challenging patients' beliefs around their fearful movements. But the group would only consider a steroid injection as a first-line intervention if the pain was severe or not improving with exercise over an acceptable period of time. And that would be a minimum of 6 weeks, possibly up to 12 weeks if possible. And then beyond the programme of physiotherapist-led exercise, further referral for investigation or orthopaedic opinion would be considered for patients whose symptoms remain unacceptable despite this appropriate period of engagement over 6 to 12 weeks, or if the patient remains anxious or unconvinced about their treatment approach. So did the expert group consider the role of lifestyle, sedentary behaviour, metabolic factors, when assessing and treating patients with this particular pain presentation? And the majority opinion was that they would consider an assessment of sleep, nutrition, alcohol levels, physical activity and smoking, with promotion of behavioural change where relevant to the patient. However, how to recognise, implement and support behaviour change was unclear, but the majority opinion of the group was that brief interventions, so interventions that could be conducted alongside usual physiotherapy treatment consultations, but brief interventions should be incorporated to make every contact count in this context. So if exercise is prescribed, what are the preferred parameters guiding this prescription? So in terms of the type of exercises from the expert group, the suggestion was that you can use isometric, isotonic or eccentric exercise according to what is most acceptable to the patient, while still providing a sufficient stimulus to challenge what is weak and to work the patient to fatigue. The recommendation was to prescribe exercise that challenges specific functional difficulty. So for example, reaching to a shelf, doing a push-up, lifting some weights, serving at tennis, but these functional movements should be broken down into the component parts and then should be retrained within the limits of the individual patient's acceptable symptom response. And loading should be staged according to the patient's ability and their symptom irritability. So very much a symptom-led type approach. But beyond this, we couldn't achieve a majority opinion on more specific parameters around exercise prescription. In terms of the number of sets, the number of repetitions of exercise, the group agreed that this should be individualized and again, based upon acceptable symptom response and then the functional requirement. So for example, those patients who require speedy movements versus sustained movements, this should be considered in the exercise prescription. But beyond that, the group couldn't achieve a majority opinion on more specific parameters. And in terms of the frequency of exercises, the recommendation was that if patients are exercised to the point of muscle fatigue, then they should exercise on alternate days. But if heavy load or plyometric exercises are included, this should be limited to exercise over 2 to 3 sessions per week. And again, beyond those basic recommendations, majority opinion couldn't be reached. So as I'm talking through this, and perhaps after the lecture, these are the kind of things that you could reflect on. Do I agree with this output? What are the reasons for the differences? What are the reasons that might have informed the recommendations of the expert group? So how many exercises are prescribed? Well, the group suggested that a minimal number of different exercises, and rarely more than 3 in total, should be prescribed. that the exercises should be adapted to address the specific functional difficulties of the individual patient and developed in the context of their current capability and deficits, and also their time to devote to exercise. But again, the majority opinion on more specific parameters was not reached. And in terms of intensity or the effort of the exercise, this should be adapted according to patient-specific acceptable symptom response. Again, so the old nugget, painful versus painless exercise. What did the group recommend in this domain? Well, the view was that exercise could provoke pain, providing that it settles sufficiently to enable the patient to perform the next set of exercise shortly afterwards or within a session. But pain provocation was not seen as an essential feature of the exercise as long as the patient was being sufficiently challenged by the exercise. And in terms of duration of exercise program, the clear recommendation from the group was that this should be a minimum of 12 weeks engagement with an exercise program, but some patients will require longer, especially those with a longer duration of symptoms or with higher levels of fear avoidance, and this could be up to 24 weeks. And that's a critical thing for physiotherapists and other clinical colleagues to keep in mind. Making decisions about the effectiveness or the natural history of a condition before that 12-week period might mean that you're missing potential to improve. So which factors or characteristics do the group see as important indicators of prognosis? A whole range of factors, perhaps not surprising, including the patient's attitude about pain and exercise, fear avoidance, litigation, lifestyle factors featuring, which you'd expect given that the group recommended that these things were assessed, multiple pain sites, the levels of baseline pain and disability, previous experience and response to treatment. Interestingly, patient expectations regarding recovery and physiotherapy. We now recognise that expectations can have an important impact on the recovery trajectory. Also comorbidities, levels of self-efficacy, psychological distress, and their social circumstances, including employment, social engagement, and so what is the expected prognosis of rotator cuff syndrome or now rotator cuff related shoulder pain? Well, the group felt that the prognosis is likely to be favourable, but this will take a minimum of 12 weeks, but further improvement might be expected for up to 24 weeks. And again, this is the important information that you might choose to discuss with your patients. Okay, so if I can just move to a close now, I think with all studies, it's really important to recognise the limitations and what you can infer and what you can't. And one of the big issues with a consensus study like this is that clearly the recommendations or the points of reflection are influenced by the experts involved. And if you can think beyond this group of experts and the influence a wider range of people might have had on the recommendations and the majority opinion. So that's always something to bear in mind. But I do think the process and the outputs can be really useful points of reflection for clinical practice. So to reflect on what's important in the history, how do I undertake a physical examination with reference to the expert group, what is my preferred terminology and why do I prefer that in contrast to other terms and in contrast to what the group have suggested, and also the range of factors that might impact on prognosis. So hopefully you've got some points of reflection to start a discussion with close colleagues, with other colleagues. What are the differences and why do we have those differences? In the absence of a suspicion of red flag pathology, the group suggested caution regarding the use of imaging. If the index of suspicion is raised, then imaging might be considered, but in the absence of that index, then caution should be exercised with regard to the use of imaging. And exercise is currently recognised as the mainstay of treatment for rotator cuff related shoulder pain. That might be challenged over coming months and years, but when we are prescribing exercise, the recommendation from the group was that this should be a minimal number of exercise, prescribed to challenge the functional deficit of the individual patient, and be supported over a minimum of a 12-week period. But beyond this, there was little agreement, to be honest, and this is largely reflective of the dearth of research evidence that's available to inform optimal exercise prescription for rotator cuff related shoulder pain. And I'll stop there. Thank you.